Welcome everybody to our first DOCMS meeting of the year. We are very excited to have you all. Thank you to our members for being here and to all the new faces we have in the audience this evening. Thank you so much. We really appreciate you guys coming out this evening. For those of you I haven't met yet, I'm Marcel. I'll be serving as president of DOCMS this year. And we are very excited to start off our year with an amazing group of panelists talking with us about reproductive health access this evening. While not all of us here in this room are providing this care, we certainly all of us have been personally impacted by the policies they'll be discussing tonight. And so we are just, again, so excited to learn from our panelists and just open a lot of discussion at the end. We want to answer your questions and yeah, just really make sure that we're able to really have meaningful conversations and move things forward in this area of medicine. I'm thrilled to start by introducing my very dear friend, Dr. Avanthi Jayaweera. She was a co-resident of mine at UNC Family Medicine, now serving as a procedures fellow this year. She does 1,000,001 things, but also sits on the board of the American Medical Student Association as a graduate trustee. She's been an incredible example of what advocacy looks like both on the local and national levels. And we're excited to hear from her, and I'll let her introduce our other wonderful panelists. Thank you, guys.
Thank you so much, Dr. Scoiety, for that very kind introduction. Hi, everyone. Thank you so much for having us today. I'm especially excited, and I want to thank DOCMS for providing this space for us to talk about such an important and critical issue that we're facing really on a national level. I'm hoping that our discussion today we can dive a little bit deeper into the state of North Carolina and how access to reproductive health care has been impacted by Senate Bill 20 since last summer. I do have a line of amazing guest speakers who are also going to join me in this discussion. We will start with Liz Barber, who is an attorney. She's also the Director of Policy and Advocacy at the American Civil Liberties Union, ACLU, in North Carolina. She had first joined ACLU to help improve abortion access for minors and created Text Abby, which is a text line that connects youth to attorneys to help them navigate through the traditional waiver process. We also have with us Dr. Jonas Swartz, who is a OBGYN physician. He has also completed family planning fellowship and serves as faculty, where he splits his time both as a clinician and a researcher. He also, much of his work also focuses on health disparities and access to abortion and contraception. And then our last but not least, our final guest speaker will also be Dr. Dalia, who's a family physician who completed family planning fellowship. She also is a regional clinical leader with the Reproductive Health Access Project, where she supports a network of primary care physicians to advocate for comprehensive and equitable access to reproductive health care. And with that, I'll go ahead and get started. There we go. Just to briefly review our disclosures here. Just to go over a few disclaimers, this presentation I will be referencing state legislation and politics as it relates to access to abortion care. I recognize that this topic can be very heavy and has been very politicized. The lens that I'll be taking is purely based on science and evidence-based practices as it relates to improving patient health care outcomes. I encourage you all to engage with us in this discussion and analyzing this issue on a medical legal framework. So just to briefly go over some objectives for today, we'll be reviewing terminology and semantics related to abortion care, compare and contrast evidence-based practices for induced and spontaneous abortion. We'll evaluate Senate Bill 20 and review legal implications and the impact on clinical practice. We'll review a few case presentations by state, and then we'll engage in a panel discussion with all of our guest speakers, and we'll have plenty of time to answer your questions that you might have. So just to take a step back and kind of frame our discussion using some scientific terminology, there's been lots of different terms to describe abortion. A lot of this is in relationship with the controversial nature of this topic. So just to make sure that we're on the same page, some language that has been thrown around has been termination, abortion, elective abortion, and I highlighted that in red. As an elective procedure is often one that is not time sensitive, and this procedure would be time sensitive, so it's not necessarily elective when we use that in a medical sense. Therapeutic abortion, interruption of pregnancy, but the scientific definition of abortion is the removal of the fetus or embryo from the uterus before the stage of viability, with the viability stage being the point at which the fetus is able to live out of the pregnant person. And now to take a step back and just look at the epidemiology of this issue, abortion is really common, and 45% of pregnancies in the U.S. are unintended. 1 in 5 pregnancies end in abortion. About 1 in 4 women in the United States will have an abortion by the age of 45. And I state women in this reference as the studies did not, in this particular study, did not include gender diverse people. We also see that 1 in 4 women aged 15 to 44 worldwide has had at least 1 abortion. So I bring this context just to remind ourselves that this is a very common and safe procedure for treatment, and that us all as clinicians should be aware at least of the options and how to counsel patients accordingly. And now to look at just the landscape of who are the people that obtain abortions. I'll say that you can see them everywhere. People of all different backgrounds, all different classes, different religions, different groups are all accessing this care, which again is just another reminder to us as clinicians to be very well equipped to understand this issue and how it relates to the care that we provide. And I guess another fun statistic to mention, or just a statistic just to highlight, is about 60% of people who have taken an abortion have already had a child. And sometimes I feel like with some of the conversations we've had with the media, sometimes that can be framed differently. But again, just to go back to the evidence and look at the research as to who is being represented by the DOCMS. And again, now to review some other statistics, just to reinforce how common this care is. In this study presented by Barber in 2016, showed that about 2/3 of abortions occurred at least 8 weeks of pregnancy or earlier, and about 88% occurred within the first 12 weeks. Now, this proportion has definitely been shown to be impacted by the restrictions on abortion care, where we see a shift to later gestations because of the barriers that patients are accessing to obtain access to care. So what are some reasons people may seek induced abortion? Well, it's typically not just one reason. Sometimes you can find scenarios of unexpected pregnancies, different life circumstances, whether it might be changes in the relationship, housing instability, financial implications. There might be some pregnancy complications, such as when we see previable premature rupture of membranes, or in other words, when the sac of the pregnancy ruptures early in pregnancy and increases the risk of severe complications such as sepsis and other life-threatening complications. There can also be instances where we see increased risk to maternal health, and as well as fetal health issues as well. So multiple different reasons why people seek this service, and again, important to put that into context when we're looking at this issue as a clinical issue. And now just to review some of the similarities in treatment options between induced abortion and spontaneous abortion or otherwise miscarriage. So we see in less than 11 weeks, there are options for medication treatments as well as aspirations or pregnancies, dilatation of curettage or curettage. The short curettage method is not as widely used. We now use the standard of care is uterine aspiration. And these options are basically the same options that we see in miscarriage. And I go down by different gestational ages in terms of the options of care, again, to highlight that abortion is not a silent issue. Any restrictions to reproductive health care can also impact other instances when we don't use very same services. And we'll go this a little bit later into the presentation, but especially when we're seeing different legal conversations about restricting access to the mifepristone, for instance, we see that's not only going to impact people who are going to access abortion care, but also access treatments for early pregnancy loss or in other clinical scenarios. And then as we're seeing additional restrictions being placed on abortion care, we are also seeing that oftentimes the barriers to accessing care can be essentially inaccessible for patients, and there are other resources for patients to actually self-manage their abortion or self-source their abortion. The definition of this would be using a combination of medications or herbs, often misoprostol or a combination of mifepristone or misoprostol to end pregnancies on their own. This is pretty much clinically indistinguishable from spontaneous pregnancy loss. It is safe with modern methods. And just to highlight the point that if we do encounter this in our clinical practice, that there is no state that requires reporting of this or reporting of suspected self-managed abortion. I think it's really important as we encounter that we're using a harm reduction mentality, as in other scenarios of healthcare. For instance, if we have a urine drug screen that came out positive for a substance, we're not going to authorities and reporting that. And now to kind of switch to another layer of that same thread, when we talk about criminalization of pregnancy, with this also becoming a more highlighted issue in the media. I'm sure many of you might have seen the recent charges that was placed on this patient who had miscarried at home. I'm not going to go into the details of that case, but just to highlight that us as healthcare professionals, there's no rules for us to report these cases, and in fact, it's a direct violation of HIPAA. And among those who were reported to have committed a pregnancy crime, 40% of those informants have been healthcare associated. And again, there's no reason for us to participate in criminalization of pregnancy care. But also another layer of that is just being mindful as whenever it comes to reporting, that our personal biases can also influence the instances when we do report and we don't, and that can often open up more instances to do more harm than good, particularly in communities of color. So why is this important? Why, who does this issue really impact? We do see that the disparities that we've already seen in access to maternity care has been further exacerbated by abortion restrictions, and we've seen the same pattern across the country. We've seen this in other studies as well. So it's no surprise that we're seeing that abortion bans worsen the already deadly Black maternal mortality rate, and just access to all reproductive healthcare access. And just as we mentioned, a lot of these methods are used for other areas of reproductive healthcare. So making sure that patients have all of their options is absolutely essential to ensure that we get the health outcomes for maternity care. And I also wanted to take a second to also highlight the importance of the reproductive justice movement, especially as it relates to increasing the likelihood of accessing equitable outcomes in maternity care. I'm leaning on the definition of Sister Song, which is a coalition of marginalized groups, particularly groups of color, who are coming together and developing a framework that focuses on the human right to maintain personal bodily autonomy, to have children, not have children, and parent the children we have in safe and sustainable communities. I wanted to bring attention to this because this was led by 12 Black women in 1984, and this came out of the concerns of a lot of the the reproductive health care movement not including the voices of our marginalized communities who are often affected by this issue to a higher degree than others. And just also to highlight that whenever we focus on any issues on the majority of people, and in this case, the majority of people who have the capacity to experience pregnancy, we will always underserve those who are experiencing the highest degrees of reproductive oppression. So just to build some space that I recognize that this presentation we're focusing a little bit more on abortion care, especially as it relates to SB 20. But when we're talking about improving access to reproductive health care and equity in particular, this is only one segment of that broader issue. And with that, we will transition to looking at reproductive care from a medical context, and I will pass over the mic to Ms. Barber.
Good evening, I'm Liz Barber. I'm the Director of Policy and Advocacy at the ACLU of North Carolina. Thank you all for having me here tonight. Yes, most would like you to unmute.
Sorry. We go. I am a lawyer, like I said, but I really speak to the policy components of things. I am not a healthcare compliance lawyer, and so you'd have to reach out to your own compliance lawyers for those types of questions. So I wanted to start by going back before SB 20 and even before the Dobbs decision to sort of lay out where we were in North Carolina as far as abortion access pre-Dobbs. And so that was a little over a year ago now, 2 years ago. North Carolina on the books, we had a 20-week ban, meaning that you couldn't have abortion after 20 weeks. That was on the books. And I say that meaning that the legislature had passed it, but it was challenged in federal court and was enjoined by the Fourth Circuit. And the Fourth Circuit said that that 20-week limit was a violation of Roe versus Wade because a 20-week limit was a pre-viability ban, and we couldn't have that. So it was enjoined insofar as it was banning abortions before viability. So the line, so to speak, in North Carolina was viability. And often people think when they talk about abortion access, it's easy to just think of where is that line. And so, is it at viability? Is it at 20 weeks? But there are a lot of additional barriers to abortion in North Carolina, both before SB 20 and now under SB 20. So I'll first start by talking about the ones before SB 20. And those are a 72-hour mandatory delay between the informed consent and the procedure, which is unique to abortion. That doesn't exist in any other medical procedure in North Carolina. Another is that mandatory informed consent by itself, and I'm not going to try to tell you all what informed consent means because you all are much better experts in that. But you're also better experts in that you all know what it means for each patient and their situation, and you all get to decide in consultation with your lawyers and your expertise what that entails. Except for abortion, the legislature has laid out what informed consent consists of. So when Dobbs came down, and those are just some of them. Another is a telehealth ban. Another is a ban on advanced practice clinicians providing abortion. It's interesting, like Avanthi was saying, abortion and miscarriage management are usually often much the same. Advanced practice clinicians are able to do things in the context of miscarriage management where the legislature prohibits them, even though it would be within their scope of practice and their scope of training for providing the same care in the abortion setting. Another is what we call TRAP laws or TRAP restrictions, the targeted restrictions of abortion providers, which go in and say, things about like how wide your hallways have to be or put HVAC limitations on things, which makes sense if you're doing really high risk procedures. It doesn't make sense in the context of abortion. And so we also had that. So in North Carolina, we really had some of the most onerous restrictions on abortion before Dobbs. Not talking about sort of that goal line of 20 weeks or viability, but all of the other hoops. And when you add all of that in, it boils down to only 9 out of 100 counties in North Carolina had abortion clinics. And that's huge. That's a huge barrier to access when you're talking about having to travel in a state that doesn't have public transportation and get time off of work and get childcare and all of that. So that's where we were before Dobbs. We were not sort of at this gold standard, right? It's very tempting to hold up Roe as the golden standard of abortion access. Whereas I really think of it as it was the floor, right? It was what states had to do. Roe did not mandate that abortion be regulated at all. And so it was already very much a patchwork of access looking across the states and how abortion was treated. They could just leave it like any other healthcare procedure and let the doctors and the patients figure it out for themselves. But in North Carolina, we were really right at that floor of Roe until Roe fell. And then the floor was sort of pulled out from under us in many states throughout the South. And so the anti-abortion folks ran to the Fourth Circuit and said, now that Roe fell, lift the injunction on that 20-week ban. And so that's how things changed nearly immediately after Dobbs, is that we went from viability to the 20-week ban and then looked to the legislature to see what would come next. So these are the laws. The ones on the left that aren't indented are the ones that existed pre-SB 20, and the ones with indentations are the changes. So you'll see first is that 72-hour mandatory waiting period. That was pre-SB 20 and stays the same under SB 20, with a huge difference in that pre-SB 20, that mandatory consent could happen over the phone. Under SB 20, it can't. So someone has to, again, find transportation, find childcare, get time off of work, perhaps make an excuse to a partner or a parent who's not going to be supportive twice. And that is, again, a huge burden, especially when you take into account that some people live several hours from an abortion clinic. For medication abortion, it can be up to 3 appointments. And you'll hear a lot of debate about this because the antis say there isn't any punishment for not showing up for the 3rd appointment. SB 20 requires that healthcare providers in providing an abortion schedule a follow-up appointment. So you have your consent, you have the abortion, and then a follow-up appointment with the patient after the abortion, and then make all reasonable measures to ensure that they come back. Well, to that patient, that seems like they have to come back. No one's telling them that they don't have to come back. It also requires healthcare providers to document all reasonable efforts made to ensure that the person comes back. And so it's not exactly clear what that means. The state mandated counseling is largely the same. Again, only MDs can provide the care. And then parental consent for minors. This is sort of a pet area of interest for me because that's how I first came into the abortion world at the suggestion of Dr. Brahmi over here, who looped me into that. And in North Carolina, again, so for minor consent, there are states out there where a minor can get an abortion without any parental consent whatsoever. North Carolina is not one of them. North Carolina requires the consent of a parent. It could also be a grandparent or someone sort of standing in loco parentis with whom the person is living with, or of course an emancipated minor. Or the young person can get what's called a judicial bypass or a judicial waiver, which is filing a petition with the court. It appears in front of a district court judge, and the district court judge considers the maturity of the young person, how well informed they are, if the pregnancy is a result of rape or incest, and whether or not having an abortion, or actually whether or not them being able to make the decision for themselves, is in their best interest. And that's what Text Abby was set up to do, is to help young people navigate that system, which is really more and more important as we see more young people losing access throughout the South. The telehealth ban stayed the same, and then this 12-week ban, so sort of the where that line is, moved from, like I said, viability to 20 weeks at Dobbs, and then 20 weeks down to 12 weeks as of July 1st. The ultrasound requirement and the targeted restrictions on abortion providers, those are less in the statutes and are more in administrative rules. And so we are still in the process of seeing what those final rules will look like. We are hoping that they will be less restrictive as of October of this year. First, we were under emergency rules. Now we've moved to temporary rules. And in October, we will go to permanent rules. And so those are the ones that you all might be very familiar with them about, according to the Department of Health and Human Services, what you have to do to be an abortion clinic and provide abortion care. And that goes through the Medical Care Commission and DHHS are the first bodies to consider those rules and then send them to the Rulemaking Commission. So there are things happening beyond just the legislation and regulation of abortion. And so one of those Avanthi mentioned was access to mifepristone. And this is really interesting. Mifepristone has been around for a long time, FDA approved in 2000, tons and tons of research, recognized by all the big organizations as safe, as effective. It is safer than Tylenol and Viagra. Yet it has these REMS associated with it, which you all probably understand REMS better than I do. But the REMS for mifepristone treat it as if it is a very dangerous drug, where my understanding is it's actually impossible to overdose on mifepristone because something about how it binds to something else, and that's all I know. And so the REMS requirement required the dispensing be in person and require the medical provider to get some special certification, which you don't have to get for other drugs that are also recognized as safe. So that's an interesting thing that came out of COVID is, COVID came and the medical profession and everyone was trying to figure out how they can still deliver healthcare services, minimizing impact. And so they decided to lift the REMS requirements and the in-person dispensing of this drug, and the sky did not fall. And so that cat was sort of out of the bag that, look, it really is safe. We've always known it was safe. We're going to stop pretending. We kind of have to stop pretending that it's not. And so first it was a temporary lifting, and then it became permanent. And so instead of the provider having to do the certification, or maybe this provider still do the certifications, providers still do the certifications, but the pharmacy also has to do a certification now, but it doesn't have to have the in-person dispensing. So then this case came down, the Alliance for Hippocratic Medicine versus FDA. And this is really interesting because, again, this is something that you all probably know better than I do, but there is a whole process for medications to get approved in the United States. And it is a rigorous process, and it's all through the FDA. It's not through the court. And there are lots of points in that FDA process for people to raise flags and say there's a problem here. And it is not 20 years later in federal court. But that's what they did. And they chose a judge. The way federal court works, depending on what it is, but something like this, you can really choose any district in the entire United States. I think there may be 14 federal court districts in Texas, and they chose one with a vehemently anti-abortion judge. And he said, yes, this is a dangerous drug, and we want to pull the FDA approval on it. So that's really problematic for a lot of reasons, for legal reasons, for medical reasons. I will not go through all of the procedure of this case because it has bounced around between the district court, between the appellate courts, and the United States Supreme Court. But it has now been taken up. SCOTUS is the Supreme Court of the United States. SCOTUS just scheduled the argument for March. I believe it's March 29th, and we expect to have a decision coming down sometime this summer. And so those bullets are the possibilities of what the Supreme Court could do with this. They could say, yes, the REMS are we need full access, in-person dispensing. They could completely withdraw approval of the drug, or somewhere in between. And so we'll see. But the bigger picture here is that part of it, it's not just about abortion, right? People could start challenging any drug. The anti-vaccine people could challenge vaccines, and there would never be a point that you're safe, that you know you've gotten this medication over the finish line. And so how could we expect Pfizer and Gilead and all of these people to continue to put millions, billions, I don't know, into developing these medications if they know at some point someone, based on something that has nothing to do with medicine and nothing to do with science, might challenge it and find some judge to agree with them and pull the plug on the whole thing. And so we saw in that case, we saw all the big pharmaceutical companies come out and file amicus briefs, which is like a third party saying, we have an interest in this case, even though we're not a party to the actual litigation. We care a lot about it. And so there were dozens and dozens of amicus briefs filed by all of the major pharmaceutical companies. And it was kind of this interesting moment because the pharmaceutical companies had really stayed out of the abortion fight. But I think in that way, the anti-abortion folks sort of poked a bear. This is another one that's really interesting. United States versus Idaho, and this is an EMTALA case. And Maybe you all know what EMTALA is. I didn't. It was passed in the 1980s. It's federal law. It's the Emergency Medical Treatment and Labor Act. And it basically says that any emergency room at a hospital that receives Medicaid funding, which I understand is like all hospitals, cannot turn people away who need emergency health care. And so the DOJ, after Dobbs and Roe fell, Idaho had a ban go into place that was a near total ban that would criminalize doctors for providing abortions, even in emergency situations. And so the DOJ went in and sought an injunction, which is saying, like, you can't enforce this law as it applies to doctors who are providing abortions in emergency rooms, at hospitals, receiving federal funds. You can't threaten them with criminal penalties. The federal district court judge said, yeah, that makes sense. You know, we have a federal law that trumps state law. We're not going to let you threaten criminal penalties under this narrow circumstances. The Supreme Court of the United States just lifted that injunction, saying, yes, you can. Yes, you can put a doctor in jail for providing an abortion to someone who's presenting under emergency circumstances in an emergency room. That one's also scheduled to be heard this spring. And again, the opinion on that will come out this summer. And then I've got to mention the Alabama case that was just Monday. The judge who wrote that opinion, it was about someone who dropped a test tube with a frozen embryo in it, and the person was charged with manslaughter. And the Alabama Supreme Court said that they could move forward with that it was a wrongful death suit, that it was an extra-uterine child who was killed. And just today, the Birmingham Hospital, it's the biggest healthcare system, I think, in all of Alabama, halted all IVF based on that, because they can't risk that someone drops something or something happens and then their employees get criminally charged. So it's really interesting. We're seeing, you know, I think a lot of people thought that this was going to end with Roe being overturned, but as we're all seeing, it's really just the beginning, and it's having ripple effects, not only in abortion access, but throughout healthcare. So I will turn it over to Jonas.
I was going to start by saying it's all not doom and gloom, but I'm not providing anything that's particularly uplifting either. So this is just a reminder that, in a way, you know, abortion, we know that abortion is important, and we know that abortion is important to improving maternal health. And what this graph shows is that we had a really big problem with maternal mortality, right? And there were a bunch of advancements in medicine that improved maternal mortality. And legalization of abortion around in the 1960s and 70s, which, you know, happened, we think of it with Roe, but was gradually happening in other states, was an important moment in reducing maternal mortality. The other thing that the slide is a reminder of is that maternal mortality is something, or morbidity and mortality is something that is disproportionately suffered by low-income individuals, people of color. And that was true before Roe and remains true today. And so we anticipate that the people who will suffer most are people of color and people who are low income who aren't able to access reproductive health care. It's also always striking to me that around the time of legalization of abortion, around Roe, that mortality was 12 times higher for non. Dobbs obviously was very remarkable. You know, we think about what the impact is in North Carolina, but we also have to think about North Carolina in the context of our country and of other states, our neighbors. And so these graphs or these maps show two different things. So on the left, the map shows you the number of clinics per state prior to Dobbs, in the time prior to Dobbs. And you can see that each state has at least one abortion clinic. I know the legend's very small, but you can see it's like 1 to 5 providers up to 21 plus providers in blue. And in December of 2022, all those Black states now have 0 abortion providers, 0 abortion clinics. So it's a pretty remarkable change in access for a very large swath of the country. And importantly, is really geographically isolating for people who live in the Deep South and still need to access abortion care. Oh, this animation is going to work. So there is a data collection effort by the Society of Family Planning, which is a research project called WeCount. And they have 85% participation of abortion clinics and abortion providing hospitals in the United States, where they collect the number of abortions that are provided each month. And so and then project the rest, or can model the rest. And so they have excellent data on the number of abortions that are being provided. What this highlights is that there are a bunch of states, including North Carolina, that have increased the number of abortions that they've done since Dobbs, and that's because people are traveling to those states. And I can tell you from my experience lobbying in the state legislature here, that was a source of consternation among our legislators, that we were, being seen or portrayed as an access state. But important states for access have been California, Illinois, North Carolina, Florida, to some extent, New York. This is a graph showing the same numbers. And so I just highlighted some key states. So at the top there, you can see Illinois and Florida in terms of the numbers of abortions that are performed each month. So the y-axis is number of abortions performed each month. The x-axis is months over time. The big drops are in Georgia and Texas. Keep in mind that this data is already after Texas had implemented its abortion ban, and so that 2,000 a month is when they were providing abortion up to 6 weeks. North Carolina's in there, and that light blue line in the middle, so sort of going up over time, around 4,000 abortions a month. One of the major concerns that I have sort of thinking about the region is that Florida has pending legislation. So they have had a 15-week abortion ban on the books. That's before their state Supreme Court. They've also passed a 6-week abortion ban. And if the Supreme Court's hearing the 15-week abortion ban, if the Supreme Court decides the 15-week abortion ban is legal, then the 6-week one goes into effect. And Florida provides a lot of abortions. And so where are those 8,000 people per month going to go to get services? This is already affected in the first year where there is data, the match. And so focusing on OBGYN providers, there's a decrease in applications to states where there are restrictions on abortion. I mean, it's a part of comprehensive training, right? And so it's not surprising. It also is true of other, certainly individuals from other specialties also are abortion practitioners, but then we're talking about young people who are going to a place to train and may themselves need to access abortion. And so there's a decrease in those applications potentially as well. We'll have to see as time goes on. So I want to talk about a case, and we're going to look at it in a couple different states, but the case is the same. So this is a 32-year-old patient who presents to labor and delivery. She's at 18 weeks gestation, and she has a highly desired pregnancy. She's been leaking fluid from her vagina for 3 days, and she's diagnosed with preterm premature rupture of membranes. Now, this is a condition, if you're an obstetric provider, or remember your time as an obstetric provider, this is a highly risky situation for the individual carrying the pregnancy. She's at high risk of infection, she's at high risk of hemorrhage. It also is a situation where there are very poor outcomes for the fetus or for the baby. Without fluid, the lungs won't develop. And so this is a situation which I learned in residency was indicated evacuation of the uterus. I trained in Oregon. And so were this patient to present in Oregon, she would be offered induction termination or a dilation evacuation procedure. She would also be offered expectant management. I will say there's also cultural differences in terms of how people care for this and the choices that patients make. And so living in the South, I see many more patients who choose expectant management. And so it's important to have that choice, but it's important to have the choice to not expectantly manage. If that same patient were presenting in Georgia, she would be told to wait until she had bleeding or fever and sent home. We've cared for a number of patients who have been in exactly that situation. They say, well, you're not sick. I don't know when you're going to get sick. Just stay by the hospital or stay close to the hospital and come back if you get sick. And I mean, we all know that acting when you can prevent an adverse outcome, acting before that adverse outcome begins to develop is much easier. It's much better care for the patient. Those hospitals are able to care for those patients when they become ill in Georgia, for the most part, from what we've heard from working with providers there. But they, those patients are sicker and they have to wait, and it's very distressing for the patients. In Texas, they may have the same situation where they're able to intervene once the patient has bleeding or infection, but they often have to seek an ethics consult before they can do so. One of my colleagues from when I was a fellow is just finished her fellowship in maternal fetal medicine. She said that her interns now think that that's part of the standard medical care, is getting the ethics consult when the patient presents with PPROM. That's just become part of the training for what you. Texas published early experience from, again, Texas banned abortion before the rest of the country, and so they were able to gather data that can sort of show the impact of these laws. And what they found was that expectant management of conditions such as PPROM or very early preeclampsia result in more morbidity for our patients, nearly doubling the morbidity that patients had at these early gestations. This is an analysis from pre-Dobbs, and this researcher, Dr. Stevenson, is really a brilliant person and speaker, and spoke a bunch at the recent Society of Family Planning meeting. So I think that she will come up with more analyses. But essentially, the states that have abortion bans have about 3 times the maternal mortality of those without abortion bans, and that's expected to increase. We have good data on the positive impacts of abortion. We know that, I guess I don't have that slide, but it improves mental health, it improves people's economic outcomes, and is not a detriment certainly to physical health, though this brilliantly designed study didn't show those physical health benefits as much as one might expect. If you're not familiar with the Turn-Away study, there's a book about it. There's a website that summarizes their findings really well. But it's the best data that we have on sort of a scientific way to study the impact of abortion. Formerly known as the National Academy of, or the National Institute of Medicine, is now the National Academy of Sciences, Engineering, and Medicine. In this systematic review, which was not done by OBGYNs even, just people who are good at reviewing evidence, they found that abortion restrictions do not decrease the rates of abortion, that they increase the proportion of later abortion, that they increase the proportion of unsafe abortion, and they exacerbate disparities in mental health, or in maternal health, So a concerning data that reinforces what we sort of know. I will not go over these consent forms. I'm going to pass it over to Dalia, but I did include in here the surgical abortion consent and the medication abortion consent, which were prepared by the state and are the required documents that we have to sign. The one thing I will say is that I think when I sign this with patients, they are initialing and signing more than I signed when I got a mortgage. It is like 15 minutes straight of just signing every clause of the document. It's pretty onerous and punishing.
Oh, you want to just hit?
Yeah. Well, I'll invite our speakers up to the front and we'll engage in the discussion. We'll start with a few prepared questions and then we'll open up to anyone who wants some questions to ask our panelists. Thank you again for joining us and helping us analyze this in a medical legal framework. I wanted to first start with just kind of acknowledging a lot of the misinformation that might be out there about access to abortion care and safety profiles, just as, especially for the clinicians in the audience who may not be directly providing this care, are there some go-to resources that we typically lean on when it comes to finding clinics in the area, or perhaps resources for patients who otherwise, just things that are publicly available would be helpful. Clinicians know.
two great resources that we have. One in North Carolina is the Carolina Abortion Fund. The Carolina Abortion Fund serves North Carolina and South Carolina. It helps with financial support, and it can also help with practical support, such as holding transportation. Unfortunately, they typically run out of money about the 15th of every month. So that's just a really sad reality, but they're a great resource. It can be hard to just get to someone that you text and then we call back. They also have a good website with a lot of information. And the other is just to know about the existence of a website called ID and Pay. And that website will show you can put in where you are and how far along you are, to the closest clinics and the gestational limits of those clinics. And that's a really important one because there's so many anti-abortion centers out there, which is pregnancy centers. And to a layperson, looking at them online, they're really indistinguishable from abortion clinics. They pretty much put themselves out there as abortion clinics. There are people, I've been told, who wear white coats who are not doctors or who wear scrubs and play with an ultrasound machine like I might. And they're really emotionally vulnerable for folks to go in not knowing what they're going into, and can also be medically harmful just because they think that they have gotten a true ultrasound and there might be something else going on or a complication that they didn't know about. So I'd be sure to know safe abortion clinics, know where the real abortion clinics are, and be able to refer your patients to that. And then also Scoiety, the text line that I mentioned earlier, that is run now under Carolina Abortion Fund. So for any patients under the age of 18, whether or not they have parental consent or not, they are a great resource for your patients.
The NAF, the National Abortion Federation hotline, is also really helpful in navigating patients care. And then I created a website to facilitate clinician referrals, and I'm happy if anybody wants to have get access to that. But it's hard. The other thing that we didn't mention, well, maybe we'll get to it, but the other thing we didn't mention is that Avanthi mentioned that or at least from one of our slides showed that the North Carolina's numbers of abortions pretty remarkably in-person counseling environment means you have to double the number of spots to see the same number of patients, and so really it's a big for and so the thing that you can do is to provide that counseling and fill out those documents with the patient if you're able. And there are some resources for created a sheet for how to do that, as well as a video that you have.
I would say that another resource for patients is the M&A hotline. So it stands for the Miscarriage and Abortion Hotline, and it's run by physicians around the country. It's a volunteer hotline that gives people information, not specific clinical advice, and just information on the medications used for miscarriage, the medications used for abortion, and it's patients from North Carolina call all the time, but patients from around the country call. And so it's a free resource, and it is often people are getting abortion pills through the mail, and it's something that you don't feel comfortable discussing with patients, that is a resource.
Thank you. Another question I had was, I understand with SB20, the abortion restriction is limited at 12 weeks. In what settings do you see that we can make exceptions to that? We should look at some referral options in North Carolina versus trying to locate resources out of state regions.
So there's three important exceptions where you can care for people about 12 weeks. So if someone's in a great incest by pregnancy. For maternal health emergencies, you can provide care to sort of any period of pregnancy if the fetus is viable. It's safe, or COVID this. So, and then for life-limiting fetal anomalies, we are able to provide care. So Though that is still an onerous process for patients. We'll see access to the state, and they're referred by internal medicine in Florida. But most places of care, yes, they do have to spend the 3 days in North Carolina. So for 4 days, right? Counseling. Made it quite work.
That also reminded me of something that I did mention that was new under SB 20, and that's something called a reasons ban. And so we also banned, there's a suspicion of Down syndrome that plays any part in the decision to terminate a pregnancy, and that abortion would be banned at any point.
And for folks who may not be providing this care directly, with this being such a complex issue that we're seeing overlaps with improved maternal health outcomes, are there other ways, or what other ways that clinicians could potentially advocate for this issue, whether it be through engaging with legislative visits or other avenues for advocacy?
I had it's sort of a general question for the room before answering that, which is how many people, physicians, PAs, kind of were familiar with some of the issues that we presented beforehand? Okay, so for those online, it's 80% maybe. And I think for many of us who see patients in an office, oftentimes patients don't know that abortion is a safe topic to discuss. So if you're an internist or you're in, other specialties that maybe aren't directly thinking about this care all the time, or pregnancy-related care. And I think signaling to your patients, they're actually doing magnets, like abortion is a safe topic here, or when you're counseling patients around contraception or pregnancy-related, saying, if you should need this service, here are some resources. And so one, just think about, is it safe for my patients to talk to me about this topic? And you can put things around your office that would indicate that. I think the other thing, and we all are part of medical societies, but thinking about advocating through your professional organization, so the North Carolina Academy of Family Physicians for me, or the North Carolina Gynecological Society. I think there's a lot of both education, so CME education, as well as discussions about how administrative burden we often hear about in medicine, but how this specific issue is impacting the care that we can provide our patients and increasing barriers to access. So thinking of this within that context as well.
I think what you said is so important, right? To feel like they can ask for it. The only thing I'd add is that I think a lot of people are confused with actually, I don't see everyone's there. My insight meeting, but President provide some data. So I won't steal her thunder, but to give proportion of people who seek it. And so helping people understand the complex laws is really a service.
So you just keep talking about abortion, keep talking about it as healthcare in your circles, in your social circles, with my families, the people, finding ways to advocate. I think at the legislature right now, it's a little bit of a lost cause, but getting involved in the rulemaking process, which I know several doctors are doing that and being voices there. It's the Medical Care Commission. They are doctors, and they are really trying to figure out what best serves these patients. And I have some hope that these voice that come down in October will help open up access.
And I'll chime in myself. I'm really interested in medical education, and me being currently as a fellow and experience as a resident and previously as a medical student, I feel like the number of challenges there were to business education in this space. And so for those that are involved in medical education or just mentoring other learners in providing space or even just sharing resources to other owners who are otherwise space. And with that, I can open up for any questions you all may have.
Hi, I'm Dalia. I work at a local public health center in Durham, Lincoln Community Health Center, and we're in the position of telling the person that she's pregnant and asking, are we happy? Is this, how are we feeling about this? And so we have a couple of smart phrases that those of you who are on Epic, sorry, but yes, that we plot into the after visit summary. So we're not allowed to refer for abortion. That's specifically in the law for FQHCs. But we are allowed to provide a person with their options. So it would be super helpful. I've been taking notes. And we have, we know about Planned Parenthood. There are very few other things we know about. Like I know about PlanCFills.org. Is that an option I should be putting on the list for the women that I counsel? Is that a legal option that I can just throw in there? Would one of you feel comfortable writing me a list of the options that you would provide to a person in this position? Because I'm happy to just plug that into the smart bricks used by our 45 provider on a regular basis.
I'm going to try to summarize that question for our folks online. But the question was, are there some other resources outside of especially in settings where there will be some legal concerns to where we can for our patients too?
M&A hotline. We already knew about the next tab.
So the law specifically made mention of referring. So I would be careful about C or because it's all in North Carolina. So you can legally we can send people to have services that are legal in those places. And I think personally, Plan C is sort of very legal in North Carolina, and so I don't distribute that information to patients. So I probably wouldn't put that on that phrase. I am happy to give you access to yeah, I think that there are, the other thing that has happened and would be totally reasonable are there are grants that will fund people to go to it's crazy to go to, for people to go to New York City, but will pay for their costs of New York abortion care, to go to Texas abortion care. So those are no through like grants to New York and grants to Oregon, grants to San Francisco, and so there are out of state options, but there's also good options that have really.
And Carolina Abortion Fund will help fund abortions that are elsewhere, and they'll even partner up with other abortion funds. Like if you're going to Washington, D.C., the DC Abortion Fund will put some funds towards it, and Carolina Abortion Fund also. So they have a whole sort of network and communications between the abortion funds.
Did you find out the first afterwards?
Yes.
I would say the other resources that are available on pregnancy options counseling is the Reproductive Health Access Project. So reproductiveaccess.org has a lot of resources, as well as READY, HEDI, the Reproductive Health Education in Family Medicine, and I can also give. But we can send out some resources afterwards, I think, if there's an opportunity to do that. So that would be.
Let's go ahead.
I'm concerned about the patient-provider confidentiality stuff and how people go in about this. If you've got an ethics committee, your information is not private. So has anybody, so obviously somebody is leaking information if they've been in an exam room. Can those folks, has anybody been prosecuted for violating confidentiality?
Just by placing information from
No, I mean, somebody, maybe a medical assistant who's in the room, how did this lady that I've hired, how did her situation get broadcast to the masses? So whoever's leaking that information can they or have they been prosecuted for a HIPAA violation? It's federal law. And I'm also concerned about the Alabama stuff, so that while I'm notified. So if you consider an embryo to be a living human being, one, what are all these IVF folks going to be? If you fertilize 10 eggs and you only choose to have 2 children, who's going to be responsible for destroying those other 8 embryos? And the other thing is, you're not considered a tax deduction until you're born alive. So you're going to consider it from inception, from conception, you need to make it tax deductible.
I'll try to summarize this to 5 minutes. One concerns about
confidentiality in these cases where there are multiple caregivers or multiple points of contact with the healthcare team, and how can you protect, I guess, that patient-provider relationship without facing legal repercussions? And then the second question, I guess, what are future consequences you all can anticipate with this view? I'm concerned about IVF and now embryos being considered to have more rights. In many cases that can influence our care and hopefully tax budgets.
I can speak to the second. We just expect to see more and more criminalization of pregnancy. We expect to see more and more attacks on healthcare. You know, they're going after abortion, or they can go after birth control, and that's probably yes. And the criminalization of pregnancy, that can play out in a whole lot of different ways, right? If you're pregnant and you're driving carelessly, recklessly, or even endangering your child, someone say yes. One state, I can't remember what state, I'm on a call every week with people from all of the ACLUs and all abortion defensive states talking about the legislation we're seeing introduced. And some states are introducing that you should have a tax exemption because you're pregnant. And that's dangerous because they're doing it. They're on that end to try to create that personhood somewhere from a place where some people will be excited and positive about it, but we're of course thinking about what that would mean later on. Someone who is using drugs and they're being criminalized, or we've actually seen some charges, not North Carolina, but elsewhere. There's a charge, the sale or delivery of drugs. And so there is this theory that you are selling or delivering drugs via the umbilical cord to the fetus and being charged with that theory. And so it's really sort of like there is no end to this. And so you've got some work on this. And I don't know of anyone being charged as far as making this information. What we do know is there's a whole lot of concern and hype about the period tracking apps, right? And the concern that law enforcement is going to get that. That is not played out. People are turning people in. Our phones are not turning people. People are turning people in. So whether or not that's a nurse or if it is a friend or a sister or whoever, I'm not sure. But it's one thing we have to worry about them in the human lives.
Hi, yeah. I have a question about how SB 20 is interplaying with SB 49 and the Parents' Bill of Rights, in particular, you know, with these young folks who are having to go protect them in the judicial process. What is the status, you know, given that this is supposed to have birth consent, what is the status of medical records for youth that are related to reproductive health now that we are kind of beyond SB 40?
I haven't studied the medical question, so I wouldn't want to answer that, but it didn't change the access to abortion part. And I hate to say this, it's such a big group, but they inadvertently opened up some access because SB 49 redefined what a parent is. And that applies to the judicial waiver statute. And so it used to be pre-SB 49, the only people who consent for a minor would be a parent, a guardian, a custodian, or a grandparent of the minor for 6 months or before the abortion. And now it opens up that one I mentioned earlier, that someone standing in local parentis. So if you live with an older sister, if you live with an aunt, if you live with your neighbor, or whoever it is that person is standing in local parentis, they would also be able to consent. That was certainly not intended by the legislature, but they were doing something else and didn't think about where that definition of parent applies. It's a good question, and we're seeing them attacking youth being able to consent to other things. So there was in the legislature, they were moving lots of bills trying to take away minors' access to birth control or minors' access to mental health care, but not abortion yet. And the short session starts April 24th. We don't anticipate more attacks on abortion in this short session just because it's so close to the general election in November. And abortion is popular in North Carolina. It's the public support abortion access in North Carolina. So we think we won't have any further attacks right now, but it won't be.
I actually have a comment. If we want a little breath of good news in all of this, I work at the VA, and we have actually been allowed now to provide emergency abortion care at the VA, which was, we were not even allowed to talk about it for the longest time. So that's a change that we've had. We can't provide elective abortion care, but emergency abortion care we can actually provide on VA property now. And it's one of those few things that made us all in our clinic, because I work in a women's health clinic there, and we also went, like, it was this huge sigh of relief. So there, it's possible we can affect change, but we have to. So it can happen if it happened at the VA.
I'll just echo that, yeah, or organizing and mobilizing communities is really the best way of applying pressure. And we've talked in so many scenarios and how these policies have really impacted how we're able to provide care to a point where in some cases we're being forced to do things that are morally wrong. And that has personally been weighing so much on me as being a learner and about to, I guess, enter the attending life in the next year. And so I appreciate hearing these stories about folks finding other ways to really force our institutions to think about even to do, I guess, our profession, the due diligence and really push when there are policies that are not good for patient care. Thank you for that.
When the SCOTUS hears the case about mifepristone, will they take into consideration the precedent setting of overturning the FDA?
Yes, they will, and that's what all of those histories are primarily about. That of saying, if this works, this could just have a domino effect, and it would affect all of the research and development of all of the other drugs. So that will be consideration.
Hey, so I'm cringing at the question I'm about to ask, but it's just been on my mind in terms of the difference in the weeks based on rape and incest and how that is further along, I guess, compared to 12 to 20 weeks. How does an individual prove it? What are the legal things that have to go about or documentation? It's already so difficult to get a sexual assault case, even regardless of being impregnated or not. But in that regard, have you guys experienced that at all, or legal standpoint, or like what if a patient comes to me saying that, like what can I tell them?
I can speak to the legal part. I don't know what practitioners are actually doing, so Jonas to that, but legally I don't know any better than you do because it's not laid out in the statute at all. So if a patient presents and says, I need an abortion, you say, oh, after 12 weeks you can't have one, they're like, well, I was raped. It doesn't say anything, whether the provider has to believe it beyond a reasonable doubt. Does there have to be a charge? Does it have to be have corroborating evidence. I mean, there's just nothing out there. There is not a requirement that it be reported to law enforcement, so presumably don't, but I mean, do you have to actually believe them? Is that an objective belief? Is it a subjective belief? None of that is laid out at all. And it's this really tricky situation because then if the provider be criminally charged for providing an abortion that's illegal, and then the onus is on the abortion provider to prove that the pregnancy was a result of rape, we just don't know. How's that putting us?
It sounds like Liz is not thinking about this. Based on should rape, I just say that we prostitute rape and we provide care if they wish to press charges. If they're minor, it's a little more complicated and flawed. About that, but for patients, they say they're sexually assaulted. I actually had I was care for a number of patients who are victims of sexual assault, including people from out of state, not able to access care out of state. Since SB20, and but I did have one patient who, was over the gestational age and then said, but I was sexually who wasn't reporting it. We know that sexual assault is underreported and underreported among abortion patients in particular because it's that's a private part that they may not wish to share, and now are forced to. So I think it is the good news is that we are able to provide care for patients and that we don't have to put additional parts that burden, but
So the reporting requirements were there previously in terms of Medicaid. So patients who in North Carolina who wanted abortions and wanted to use their health insurance, which was Medicaid for abortions, there were all rape and incest were some of the legal reasons. And so I provided care and had to fill out a Medicaid waiver attesting to the best of my, I don't remember the exact wording, but to the best of my ability, I understand that this pregnancy was the result of rape. And it's just an attestation and the signature. And so I think it's one, just to remind us that this has always been a burden for people who are trying to use Medicaid to pay for their abortions, but that it is, and in multiple contexts, both internationally and other states, that rape is one of the indications that physicians have used to be able to offer that care. And so rape and sexual assault is extremely common. We know that. And I think there is a duty to inform patients that that is an indication because oftentimes they do not know that. That's what I'll say.
Any other questions?
I was going to ask general sense about the sentiment of these things that go through the legislature, about what proportion do they pass? 51% or that, I don't know.
What percentage of bills that are introduced?
Yeah,
a small fraction.
Not tough.
1 out of 10.
One that do pass, but what portion?
Yeah. 2/3. Or 3/5, because 3/5 are exactly 3/5. The abortion ban passed along parliaments, and it was razor thin. It just takes a majority to pass, but then it takes a 3/5 of the members voting present to override a veto, and that's exactly what we have in the chambers right now. Trisha Cotham ran as Democrats, elected Democrat, changed parties, and so that's exactly how it passes.
Another question: those the folks who have done lobbying and encounter legislators, what do they say?
It depends on who we're talking to.
I understand that. I would say some all these folks would be likely to impede things or have a negative. What do they say? They will have a nice day or.
You mean what do they say back to us?
Well, to whoever is lobbying.
Look, I'm a lobbyist, so, some just won't talk to me.
Okay.
Some tell me to go away.
Yeah.
But I mostly try to figure out what might speak to them. For a lot of them, it's bringing providers in. Jonas and several other providers spent a lot of time in their white coats, like literally in their white coats, running around the legislature for folks. Not being seen with me, but, I'm not too popular over here. But, going with the Duke lobbyists or, OBGYN Society or the Society, lobbyists. Some people listen more to business voices, and so we mobilize business voices to talk about economic ramifications. We try to get more and more businesses involved in that.
Do they decline to come to North Carolina or move?
So that, to get, big tech companies to say, how are we going to get our 20-year-old coders from the Bay Area to move to North Carolina when you're passing these progressive laws? And make medical arguments that, doctors aren't going to come here, and abortion providers, you like to think that all they do is provide abortions, but they also take care of their wives and their sisters when they have complicated pregnancies. And they help them understand, abortion is healthcare and all of the different ways that is true and how that plays out. For other people, it's bringing in religious leaders and getting them to talk about it. Sometimes it's connecting them with someone of the same religion in another state and helping them have conversations that I really can't have. I can't connect with a rural Black man who grew up in the Baptist church. And it's just not a conversation that I can have with him, right? And so find someone else who can have that conversation, getting constituents to reach out to them. And so a lot of those conversations aren't actually happening between me and a legislator, but it's really finding the right person to get into the room with the legislator, so they're going to listen to more, with exceptions, right? There's some more libertarian legislators who I can't have those conversations with them, and it's important just to be in there and hear what they're hearing from the other side and try to counter that. But everything we did, we kept it to 12 weeks. But it's not enough.
I admire you.
Thank you. And I can't not talk about how this was actually introduced. And so, there's the video about how a bill becomes a law, and it goes around to all of the different committees, and people weigh in, and they change it, they tweak it, and then it's voted on in one chamber, and then it goes over to the other chamber, and makes the rounds to all of the committees, and then they vote on it again. And this bypassed all of that. And so they use this really interesting mechanism where something, this bill, SB 20, it started in the Senate, and it was an infant surrender bill. It had nothing to do with abortion. And it passed in the Senate. And then it went over, and it went through committees, passed in the Senate, went over to the House. One of the House committees amended it and changed it. And so when that happens, they have to send it back to the Senate for the Senate to vote on it again, because it's a different version than the Senate originally voted on. And so that happened, but the Senate voted it down and sent it to conference committee, which isn't terribly uncommon, but usually conference committee is just hashing out a few differences because the amendment was relatively small. But here the conference committee gutted the bill and dropped in an abortion ban. And when you do that, it doesn't go through committees and it can't be amended. So it's just an up or down vote. And it all happened in like 72 hours, which is really just unbelievable. And there were so many inconsistencies and medical impossibilities and poor drafting. Like they forgot to change the reference that made it not murder to commit, to provide an abortion. They just overlooked that, which is a pretty big omission. And if it had gone through the regular process, someone would have realized that. And so we brought a big lawsuit, a report, had to have some things enjoined. Well, would have had them enjoined, but the legislature rushed to kind of clean up some of their messes, some of the limitations and so on.
Just in terms of the lobbying, so I sat a lot of legislators, and they are politicians, and they're really good at making you think that they maybe value your opinion and maybe agree with you. And it was really a crushing process. And so I had to see a therapist afterwards. One of the things that the said to me was, I was upset sort of about counseling come into this use. What she said was, well, what are the patients? What's their perception of it? And I've thought about that as I care for patients. And first of all, many patients don't have a preconceived notion. This is just how they think that they get care, right? So they don't know the difference. And then the other thing is that patients are really grateful still that they can access care. I also provide care in Virginia. And oftentimes when I go to Virginia, I'm caring for patients who are coming from like 7 or 8 states a single day. And they are so grateful to have been able to access care. I'll say, I'm so sorry that you have to drive 8 hours. I'm just glad of it. And I think it really has given me hope and a continued drive to do this, that patients go so far and they're not focused on their hardship about it, they're focused on the fact that they are able to get care.
Thank you.
Well, they can. I do a lot of lobbying with medical students, and it's always a fun experience to give their kind of vision for the things we can accomplish in our field. The other thing I would add and kind of echo is looking for areas of agreement and using that to advance conversations in different lens. Sometimes we might see like a champion in our legislature who's really great on advocating for affordable access to medications. And so we'll use that angle to kind of advance the discussion there. Other times we also really try to praise the people who put their necks out there to support these bills and protections as well, because sometimes they get a lot of heat from different angles as well. So those are some other ways that we can support.
And money talks. Like, it's the loudest lobbyist.
That's why that's what I was
find a pro-choice candidate and give them your money. Give it to them early.
So they talk about time, talent, and treasure. You're talking about being strategic about things, and you don't have a lot of time. And I've tried to go down and do the white coat these days, and it's fun, but the only person who's going to listen to me is the person for whom I'm a constituent. And he already votes the way I want to vote. Why would I mean, I'm still going to do it from time to time, but yeah, I can see going to therapy after that because no one wants to listen to you. So the people who are there shouldn't be there anymore. And the way to do that is to take your treasure and put that towards the party that you care about and try to break the supermajority if that's something that you're interested in. And that isn't something that I have the time or the talent to figure out how to do, but there are people who do. So that's all I say. Yeah, I vote. But I'm voting for the guy who's already gonna win. So
Yeah,
like, I feel like the treasure is a little more important in terms of what I can do right now. I can still vote, but
I would just say, you know, as crushing as it is to do the lobbying and to think that this was a defeat, I do think that the amount of lobbying and the pressure, and maybe I'm kidding myself, helped it from being a 6-week ban and instead of having a 12-week ban. And it's not good enough and it's not okay, but it could always be worse. And I think I did lobbying through the lens of primary care, and there are a lot of rural representatives who really care about pipeline and workforce, and I think that's a angle that you know, bringing in medical students, nurses, like your whole healthcare team. Healthcare is something that in rural North Carolina is a huge issue. Here also in the Triangle, but it is not good for the state, and it is not good to limit access to care. And so I do think mobilizing physicians and healthcare workers is really important in ways that touch on abortion. And if you are going to talk about Medicaid expansion or retention of healthcare workers in rural areas, you can bring this in as an issue as well.
Yeah, I just wanted to give you all another round of applause. Thank you so much for bringing this really incredible topic to our meeting. We thank you.